Very good afternoon, all. This is Sripriya welcoming you to the sixth session of our foundation course in palliative medicine. Today, we'll be going through the topic of difficult pain, and we have Dr. Mary Abraham rejoining us to walk us through the session. Even though she doesn't need an introduction, as she has already interacted with this cohort, but still, Dr. Mary is a visiting consultant of the Max Group of Hospitals in New Delhi, and she was awarded the Lifetime Achievement Award by Delhi Neurological Association for contribution to neurosciences in Delhi in February 2017. And she has authored a book called Going Pain in 2019. So without much delay, Mary ma'am, it is over to you for the session.
Can I share the screen?
Sure, ma'am. Access is already given.
Good afternoon, everyone. Am I audible?
Yes, ma'am. Perfect.
Okay. So I'll just go on to screen. So now today, I have dealt with WHO's step 1 and step 2, and I think the step 3 also has been dealt with. So now we will talk about the approach to a patient with difficult pain. So we know about the 3-step ladder, in which the step 3 is the strong opioids. Okay, and that is when the pain is very severe. But we did mention that 10 to 15% of patients do not respond even to the step 3 drugs, that is the strong opioid drugs. So these are the category of patients we label as refractory pain or difficult pain. And this is a very category which is relatively very difficult to treat all as well. Okay, so there are other synonyms for the refractory pain or difficult pain. We can also call it intractable pain, persistent pain, or opioid non-responsive pain, because you even tried the step 3 drugs also. So it is defined as pain related to cancer or its treatment of at least 3 months duration that has not responded to standard treatment with opioids and co-analgesics. So there are some risk factors for a patient to get intractable cancer pain. Young age, they are more prone to be refractory to treatment. Neuropathic pain is more difficult to treat. Pain that's incident pain, that is a patient is having continuous pain, but when there is a sudden spurt of pain, that is called incident pain, that is difficult to treat. When there's psychological distress, when there's a history of previous opioid use, or where there's tolerance to opioids, or history of addiction and impaired cognition. So these are the various risk factors for a patient to get intractable cancer. So let me start off with the case scenario. A 62-year-old man with CA rectum with peritoneal and liver metastasis, he was on chemotherapy since 1 year. He never had much pain at that time. But then he developed acute intestinal obstruction with pain in the abdomen due to progression of the primary lesion. So he was taken to the ER and admitted for conservative management of intestinal obstruction. A Ryle's tube was inserted and a colostomy was done. And he was discharged after a week with advice of continuing with palliative care. Initially, he was taking step 1 and 2 drugs through the nasogastric tube along with adjuvants for pain abdomen. But the pain persisted and he had to be started on step 3 drugs orally through the Ryle's tube. But one day he pulled out his Ryle's tube. He never liked it in the first place. And he mentioned and indicated that he did not want it reinserted. Now, there was a family discussion between the palliative care doctor and the family as to how to feed him, because he was so far taking everything through the Ryle's tube. And he had also become very emaciated and weak because of the progression of the disease. And also we needed to give him the opioid drugs through the Ryle's tube. But because the patient had indicated in many ways that he did not want the Ryle's tube reinserted, we felt that it is not fair to put it in despite the patient's wishes of not having it. And that is patient autonomy. We should respect patient autonomy. He was very weak and we could have easily put it in, but because we wanted to respect his wishes, we did not do it. So he had a chemo port. So he was started on maintenance fluid through the chemo port. But the pain grew worse and he was started on transdermal fentanyl patch, 25 mics per hour, along with oral transmucosal fentanyl citrate or OTFC. That is the fentanyl lollipop, which has a strength of 200 mics SOS. But there was no relief of pain and he continued to be on agonizing pain. In fact, he was even shouting with pain. And the family was extremely distressed because they did not want to see him suffer. So what do we do for this patient? Because he was not responding to the strong opioids given both transdermally as well as transmucosally. Now, what are the steps to treat difficult pain? So let us now discuss how to treat such cases. First of all, we have to review the treatment protocol and review the patient's condition. Then we have to manage it either by pharmacological or non-pharmacological methods. The pharmacological methods include route conversion of the drug or route rotation or adding adjuvant drugs. And the non-pharmacological methods includes interventional pain management, psychological therapies, physical therapy, alternate therapy, spiritual therapy. Okay, this is a broad outline on how to treat these patients. So now let's review the patient. It's useful to remember the acronym mnemonic ABC. A is the patient adhering to treatment? B is believe the patient about pain. Please remember, patients generally don't fake pain. Okay, when they say you have pain, you have to believe it. As Margot McAfee aptly put, pain is whatever the experiencing patient says is existing whenever he or she does. In simple terms, pain is what the patient says hurts. Then the C is a comprehensive pain assessment has to be done again. Go through the pain characteristics. You know the pain characteristics, no? PQRSTU. Then go to the functional history. Is he able to walk? Is he able to do his normal activities? Is he able to interact with the family? Review the drug history and the non-drug history. Examine the patient and review again. That is a comprehensive pain assessment. And then another C is correct the correctable factors. If there's an effusion or ascites, we may need to tap it. If there's an underlying infection, treat it. If there's insomnia, you have to take care of it because sleeplessness decreases the threshold of pain. Anxiety, nutritional state, all has to be looked into if they are correctable factors. So let's look at adherence to treatment. Now we have written a prescription like this, which is shown on the right side. But is he taking according to what you have said, or is he taking it on his own without following the dose regime? So that is something we need to do. We have to review the adjuvants, whether the gabapentin is sufficient or whether lorazepam is adequate. What about the bisocanol? Is he having constipation? So you have to see whether the patient has understood these dose regimens. For that, you can use what is called teach-back techniques. That is, you ask the patient or the attendant to tell exactly how they're giving it. Is the morphine given every 4 hours and are the SOS doses being given for breakthrough pain? Is the paracetamol being given 3 times a day? So all these things have to be checked again to whether they are following what you have written in the prescription. Now, there are some reasons for opioid ineffectiveness in such patients. The most common reasons are the accumulation of toxic metabolites of morphine. We all know that morphine is metabolized into, they produce the metabolites, morphine 3 and 6 gluconides. And it is some of these metabolites that accumulation can lead to the toxicity of the morphine. Or is there a progression of the disease? It's a very common treatment cause for intractable pain. Or is there a new pain type? Earlier he was having nociceptive, now maybe he's having a neuropathic, or in this patient we discussed he's developed a bowel obstruction, or is it a spasticity. So we have to see whether it's a new pain that has also emerged. Then, like I mentioned, the neurotoxicity because of the intolerable side effects. They can manifest as sedation, delirium, hyperalgesia, or myopia. Or is a particular route that you're using, has that failed? Is there a poor oral absorption for any reason? It could be a outlet obstruction. Okay, that itself can cause the drug not to be absorbed. Or is there a diminished transdermal skin absorption? Or if you have a catheter in or a needle in, is there a blockage? Is there a dysfunction, malfunction of the catheter, whether it is IV or subcutaneous or even the spinal drugs that are there? And also, last but not the least, we have to evaluate whether there are psychological, social, or spiritual factors. So I mentioned about the pharmacological, non-pharmacological. So let's discuss some of the pharmacological methods of management of difficult pain. The first is opioid manipulation. That is, you can either convert the route from either oral to parenteral or oral to transdermal, or you need to switch the route, switch the drug. That is what is called opioid rotation. Or we may need to add adjuvants like antidepressants, anticonvulsants, NMDA antagonists, antispasmodics, local anesthetics, corticosteroids, and even cannabinoids. Now let's talk about route conversion. In this, the same opioid is given, but through a different route of administration. Like I mentioned, oral morphine can be converted to intravenous morphine, or a transdermal fentanyl can be converted to intravenous fentanyl. Now, both with IV and subcutaneous route, you can get fairly good serum concentrations of the drug, which are effective for the patient. And both morphine and fentanyl can be given intravenously as well as subcutaneously. The conversion factors we must remember: oral to subcutaneous to intravenous is 3:2:1. That is 30 mg oral morphine is equal to 20 mg subcutaneous morphine and 10 mg IV morphine. These factors you should remember when you want to do a route conversion. Now, the route conversion, if you're giving intravenous opioids, you can give it as a continuous infusion for continuous pain. But if there is incident or breakthrough pain, then you can add an intermittent bolus as well. So what is patient-controlled analgesia? It is a method by which the patient gets a continuous infusion, what is called a basal infusion. And then there is a remote like this, what is shown over here. This is a remote, and this is also has a remote, it's not shown over here. That can allow the patient to give an extra bolus when the patient has an incident pain, okay, or a breakthrough pain. So these are some disposable elastomeric pumps that are available, and you fill this balloon-like thing with the drug, and this will go continuously and as well as a bolus when you want to. The patient can press this button. Or you have a continuous ambulatory drug delivery pump or a CADD pump, in which it is not disposable, but you have to fill the drug into this, and there is a catheter as well as there is a remote. Now, there is no evidence of the superiority of parenteral to the oral route to control intractable cancer pain. But the European Association of Palliative Care recommends the use of parenteral opioid infusions in cases where the oral or the transdermal opioids are ineffective. Now, the next pharmacological manipulation that you can do is opioid rotation in difficult cancer. In opioid rotation, you're using this different opioid, but the same route. That means, like orally, you're giving morphine, but you just change to oral methadone. The indications are, again, intolerable side effects like neurotoxicity, or poor analgesia despite titration of the morphine. Then you can give a switch over to another opioid. How does it work? This is because of the phenomenon of incomplete cross tolerance. That means there are some opioid receptors that are still receptive to another opioid. All the receptors are not completely blocked because of the previous opioid. And this is called incomplete cross tolerance. Okay? And because of that, when you give another opioid, it is acting on certain receptors that are still available for it to be active. And it also produces greater than anticipated potency when you're using another opioid. So when converting from one opioid to another, you remember 3 basic steps. First of all, you have to look at the equianalgesic table to find out what is the equianalgesic dose. For example, you're converting from morphine to fentanyl, okay? And the patient is getting 60 mg morphine. So the conversion is 25 mics per hour of fentanyl. So there is a conversion table, and you have to look at that to see how much of morphine is equivalent to what is the equianalgesic dose of that particular drug. Once you calculate the equianalgesic dose, if the pain is well controlled, then you have to reduce it by 50% with the new drug. But if it's a poorly controlled pain, then you have to reduce it only by 25%. So once you calculated the equianalgesic dose and the patient is having poorly controlled pain, then you reduce the dose to 25%. The exception is methadone, which I will talk about later. And last but not the least, you must also prescribe a rescue drug also. So that rescue dose, so that if there is a breakthrough pain, you must tell them exactly how much to give for treatment of breakthrough. That's called a rescue dose. I mentioned about opioid-induced neurotoxicity. The cause of it is the accumulation of the metabolites like toxic metabolites like morphine 3-glucuronide and norepinephrine. And they cause the neurotoxicity symptoms like sedation, delirium, myoclonus, hallucinations, hyperalgesia, and even seizure. Now, regarding the opioid rotation, the only other drug other than morphine, strong opioids that are available in India are methadone and fentanyl. And methadone is relatively inexpensive and can be given orally, but they are all under the same legal control as morphine. So that means they are all scheduled drugs. Now, the use of methadone, I know this has been dealt with in the previous session, but I'll just briefly go through it. The advantages of methadone are its high potency. It is very effective for neuropathic pain as well. That is, which morphine may not be that effective for neuropathic pain. That is because it has, it's an NMDA receptor antagonist, and also it is a serotonin norepinephrine receptor reuptake inhibitor. So because of these two properties, it is good for neuropathic pain. It has no known active metabolites, unlike morphine. It has a long half-life, 8 to 12 hours. So the dose is much less as compared to morphine. It is slowly eliminated, and so there is less risk of breakthrough pain. It does not accumulate in renal impairment, so it can be given in patients with renal dysfunction. Less tendency for tolerance and no cross tolerance, and it is a relatively inexpensive. But there are a lot of disadvantages as well. The one and the most life-threatening one is the occurrence of ventricular arrhythmia like torsades de pontis, and that is because of the QTC prolongation that is present. Titration is difficult, so there's a risk of overdose, and it has to be given only by experienced palliative care specialists. So what are the indications of methadone? First of all, it is used for opioid rotation, particularly when the intractable pain is there. It is less expensive. It is also given for true morphine allergy and for the treatment of neuropathic pain for the reasons I mentioned earlier. But there are contraindications. If the ECG shows a QTC prolongation of more than 500 milliseconds, if there's no reliable caregiver, if there's a history of sudden unexplained death in the family, or if the certain drugs like azithromycin, fluconazole, amitriptyline, there could be interaction. Excuse me. Now, when you want to convert to morphine to methadone, if the patient is getting less than 60 mg morphine per day, the oral morphine equivalent of methadone is 2 to 7.5 mg per day. If the patient is getting 60 to 199 milligrams of morphine, the equivalent is 10:1 conversion. That means 10 mg morphine is equal to 1 milligram of oral methadone. And if the patient is getting more than 200, then the conversion is 20:1. So they are available as 5 milligram tablets and syrup of 5 mg per ml. Now, as per expert consensus white paper, the equianalgesic doses suggested for methadone are very conservative, what I mentioned earlier. So we do not need to account for incomplete cross tolerance, which means we do not have to reduce it to 25 or 50% when we're converting the drug. Okay? Now, another strong opioid that we can give through the transdermal route is transdermal buprenorphine. It is also another option for opioid rotation. It can cause better pain relief, good tolerability. It can control neuropathic pain and breakthrough pain also. And it's available as Buvalor patches of 2.5 mics per hour or 5 mics per hour. And each patch lasts for 7 days. Now, having gone through that, our management, then let us review the cause of pain. That's also very important when you're treating with a patient who is not responding to your drugs. First of all, is it nociceptive or neuropathic, or is it mixed pain? Or is there a need for an adjuvant drug? Okay. Now, I have talked about this earlier, that nociceptive is at the tissue level. Anything beyond the tissue, from the peripheral neuron to the dorsal horn, to the spinal cord, to the brain, all this becomes neuropathic pain. Sometimes you could have mixed pain as well. Ketamine and difficult neuropathic pain. Ketamine is very good for neuropathic pain because it blocks the NMDA receptor in the dorsal horn of the spinal cord as well as in thalamus. And NMDA antagonists are used when the neuropathic pain is unresponsive to antidepressants and anticonvulsants. So as a third line or second line treatment of neuropathic. It can be given through various routes. I think I've dealt with all this earlier, so I will not go through this. Suffice to say that you can use what is called as burst ketamine for the treatment of neuropathic pain. Burst ketamine is you give a burst or a pulse course of ketamine for a maximum of 5 days using syringe pump. You start off with 100 mg per 24 hours through a syringe pump, give it for 3 days. If it's not effective, then increase it to 300 mg in 24 hours for 3 days. And if it's not responding, then you can increase up to 500 mg per day for 3 days. And if it is not effective, then we have to stop. So this is what is called a burst ketamine or a pulse course of ketamine for the treatment of efficacy. There are various side effects. This also I've dealt with earlier, so I won't go through that. Now, some local anesthetics can be given for difficult neuropathic pain. And they are used as a second line treatment for severe intractable crescendo kind of neuropathy. It can be given as a local anesthetic infusion in a dose of 5 mg per kg over 1 hour with cardiac monitoring, or as a topical lidocaine patches. Okay, that's also available, and I've discussed this in my earlier class. The other topical drugs to treat neuropathic pain are topical capsaicin. Now, capsaicin is a pungent component of chili pepper, and 8% capsaicin may be used to treat neuropathic pain, but it is not available in India. Topical gabapentin is also available to treat neuropathic pain. So if you look at the neuropathic pain ladder, the first line treatment is amitriptyline, pregabalin, gabapentin, duloxetine, and lidocaine patch. The second line is opioids like tramadol and methadone. And third line, you can use baclofen, mexiletine, capsaicin patch, and ketamine. Now, let us discuss something about cannabinoids in the use of difficult cancer pain. We all know that cannabinoids has been used for various ailments since ancient times, but in medicine, the use is restricted because of legal social concerns related to drug abuse. But a few symptoms in cancer can be resistant to the current palliative care treatment options. There are no robust clinical data, but there's definitely a risk-benefit ratio. But because there is no clinical data, it's not routinely included in our palliative care treatment. Now, endocannabinoids act on the two receptors in the central nervous system, namely CB1 and CB2. CB1 receptors are found in the brain, spinal cord, but they are poorly expressed in the brainstem, and that is why there is a low incidence of respiratory depression with cannabinoids. And these CB1 receptors accounts for the well-known psychotomimetic effects of cannabinoids, like the euphoria and the hallucinations that happen. The CB2 receptors are mainly found in the immune system. It has no psychotomimetic effect. And this has been investigated now for its therapeutic effects, namely analgesic effects, anti-inflammatory effect, and the anti-neoplastic effect as well. The two phytocannabinoids that have been extensively studied are THC, which is tetrahydrocannabinol, and CBD, which is cannabidiol. Okay, just remember THC and CBD. Now, nabiximol or Sativix is an oromucosal spray containing a 1:1 combination of THC and CBD. Okay, now THC causes the psychoactive component and CBD has the anti-inflammatory property. This has been well tolerated and found to produce improved analgesia and opioid unresponsive cancer. So the preparations that are available are the one which has THC dominant. Okay, that is a psychotomimetic. They are dronabinol, which is a synthetic THC. It can be given orally, or nabilone, that also can be given orally. Or you can have a CBD dominant drug like 99% pure oil based on cannabidiol. Okay, and the dose is 5 mg per kg per day. Or you have like nabiximol, like I discussed previously. It is a 1:1 ratio of THC and CBD as an oromucosal spray. But just remember, these are all Schedule 1 drugs and there's a high potential for abuse of these drugs. So if you look at cancer pain, the analgesic effect of cannabinoids are relatively weak. I mean, they're comparable to the weak opioids, not to the strong opioids. And the effect can last up to 6 hours. So you have to give it every 6 hours. So it can be used as a third or fourth line treatment for neuropathic pain when conventional treatments fail. Remember, the equianalgesic dose of 20 mg THC is 120 mg of codeine. Now, it can also be used for the chemotherapy-induced nausea and vomiting. And the cannabinoids used for that are dronabinol and nabilone. I won't go through this because this is not coming under the ambit of pain. So I'll just skip these slides. Just remember that they can be used for chemotherapy-induced nausea, vomiting as well. Now, what are the side effects of cannabinoids? The first is a neuropsychiatric effect because of the THC component. So they can aggravate pre-existing anxiety, schizophrenia, and depression. They can cause impaired cognition like excess sedation and impaired motor skills. They can make the patient infection prone because it reduces the host response. And they can have cardiovascular side effects like hypertension, hypotension, tachycardia. So you must avoid it with heart disease. So what is the use of cannabinoids in palliative care to sum up? It can be used as a third or fourth line treatment for neuropathic pain. It can be used for chemotherapy-induced nausea and vomiting. It can be used for cancer anorexia, for HIV-related cachexia, for multiple sclerosis-associated spasticity. It improves mood and because of its antipsychotic effects. It has anti-cancer activity. It can be used when there are sleep disorders and where there are seizures. So what is the current status of medical cannabis in India? No, sorry. The medical cannabis, what's the latest on that? So this was an article published in Frontiers in Pain Management in May 22, in which they said that medical cannabis had significant improvement in pain measures and a decrease in other cancer-related symptoms. It reduced the consumption of opioid-based analgesics and the side effects are minimal. So there is a role of medical cannabis in the treatment of cancer. What about the status of cannabinoids in India? Is it legal? Well, in foreign countries, it has been used in the treatment of neuropathic pain in multiple sclerosis and also for refractory pain and cancer. In India, there was a petition in the Delhi High Court challenging the provisions of NDPS Act. NDPS Act says cannabis is not legal and it's a scheduled drug. So this was challenged in the Delhi High Court, and the central government has informed the court that the use of cannabinoids is allowed in India for medical and scientific use as per the law, and it is not completely banned. So that is good news for the use of cannabinoids. Now, corticosteroids as an adjuvant for difficult pain. Yes, it can be used for a number of conditions, which I've talked about earlier also. Okay. So the first line drug would be dexamethasone, and it can provide short-term relief of pain and beneficial for those with less life expectancy. Now, GABA receptor agonists. Now I had mentioned it earlier also, they potentiate the inhibitory effect of the GABA, which is an inhibitory neurotransmitter. Okay, so the GABA receptor agonists are actually enhancing the inhibitory effects of GABA. So we have two, one is GABA A and GABA B. GABA A receptor agonists include the benzodiazepine, of which only clonazepam is used for neuropathic pain. And GABA B receptor agonist is baclofen. Now, baclofen can be used for refractory neuropathic pain because it binds to the GABA B presynaptic receptors. Okay, you can use for treatment of spasticity, trigeminal neuralgia, hiccup, and musculoskeletal spasm. You can start in a low dose of 5 mg PD and you can go up to 20 mg TDs. And the various routes of administration, it can be given orally as a topical cream, and even an intrathecal pump can be used with GABA in it, and with the baclofen in it. It's called a baclofen pump for treating the spasticity. Now, bone pain is another important cause of refractory pain, and it is basically because of the skeletal related effects, and it can be quite agonizing. So the various options to treat bone pain, which I've talked about earlier, are the steroids and NSAIDs, calcitonin, but the latest review shows that it may not really improve the quality of life. But the mainstay of treatment of bone pain are the bisphosphonates and denosumab, because it inhibits the osteoclast-mediated bone resorption and reduces skeletal-related events. And of course, there is palliative radiation as well. Now, another important cause of refractory cancer pain is malignant bowel obstruction, particularly in advanced cancer, which is inoperable. So for this, octreotide has been found to be very effective. The octreotide is a somatostatin analog. It's a synthetic preparation, and it can be given as a dose of 300 mics in 24 hours as a subcutaneous continuous infusion for 6 days. And the recent guidelines, that is the MASCC guidelines, say that octreotide is a drug of choice for malignant bowel obstruction. It can be combined with steroids and hyoscine as well. So we now looked at all the pharmacological options. So let us now discuss the non-pharmacological options of management of difficulty. I had mentioned this in my earlier thing that in 2000, there was this step 4 to the WHO pain ladder, which included nerve blocks, epidurals, PCA pumps, neurolytic blocks, and spinal cord stimulators, and intrathecal pumps as well. So it's for those category of patients who are not responding to the step 3 drug. So this can be kept in mind, these neurosurgical interventions. So what are the interventions that we do? Some of them are the patient control analgesia pump, giving various nerve blocks or epidural blocks. Then you can give peripheral neurolytic procedures using phenol and alcohol. Or you can use intrathecal opioids or a spinal cord stimulation. So these are the various, some of them basic interventions like these, and these are all advanced interventions. Okay. So they can be considered in patients with severe side effects from the drugs that you're giving, like strong opioids, and whose life expectancy is more than 3. There are also some central neurodestructive procedures as well. They are not commonly performed, And they include rhizotomy, gangliotomy, chordotomy, myelotomy, tractotomy, thalamotomy, and even operations on the limbic system like cingulotomy. So many OMIs. But they're very rarely done. And they are given only when the life expectancy is less than 3 months because they have a high risk. So the risk benefit ratio should be assessed when we go for these advanced neurodestructive procedures. I have not seen any of them being done for cancer. So they are very, very rare. The other non-pharmacological therapy that you can think of is dry needling, acupuncture, biofeedback, psychological therapies, physical modalities, spiritual therapies, and alternate. Now, this is a patient getting dry needling. This is what I do for them. This is for the treatment of back pain. So they can be used to treat muscle spasm and myofascial pains associated with severe cancer pain. Sometimes when cancer pain is very severe, it can cause a lot of muscle spasm. And that can be treated using dry needling. So the tender myofascial trigger points the affected muscles form in patients with spasm. And that's because of the sustained contraction of the muscles. So how does dry needling act? They produce reflex relaxation of the muscles and improves the hypoxic local energy crisis because of the sustained contraction. And they release the trapped inflammatory mediators that are in the shortened muscle. The physical modalities are also there, like heat, cold, tense, teaching all the physical activities and exercises and all. So they are also useful in the treatment of difficult pain. The psychosocial and spiritual issues include fear, anxiety, depression, anger, guilt, financial issues, fear of the future, concerned about loved ones and their future, and the loss of role and role reversal. The head of the family may no longer be the head of the family. Maybe the wife has taken over his role. Okay, that also can cause a lot of emotional strain on the patient. And sometimes they even question God. So how do you treat it? By counseling, communication, medications, forming support groups like art therapy, music therapy, dance therapy, and providing financial support for the children's education. Now let us go back to our case scenario and discuss what was the cause of this patient's intractable pain. Now, first of all, there could be medical reasons why he was having intractable pain. That could be either progression of the disease, the colostomy site definitely looked unhealthy in this patient, or is there a failed route of absorption? The transdermal patch that we were giving that was probably not working anymore, or were there other psychosocial concerns? Now, what was done for this patient? He was readmitted to the hospital. A colostomy was examined. It was found to be non-functional. So that was the cause of refractory pain. Then the opioid route was converted from transdermal. They made it into intravenous fentanyl with supportive care. And in a matter of a few hours, the pain subsided. End-of-life care was instituted, and this was explained to his relatives, and he expired free of pain 2 weeks later. So what were the non-pharmacological interventions? In this patient, maybe 2 drug-centered or intervention-centered. Good non-pharmacological interventions have also been beneficial. So let us look at the psychosocial concerns in this patient. This gentleman was a highly educated retired doctor. He had no financial concerns because the entire cost of his treatment was fully covered. He had a very supportive family, his wife and daughter. They were constantly by him, taking care of all his needs and concerns. The wife was a main caregiver and had taken over the head of the family role, managing all the hospital, medical, and financial issues. But he was depressed because he knew that there was no cure for his cancer and he would not live long. So he had a sense of hopelessness, helplessness, and powerlessness. He had also psychosocial issues. He experienced loneliness and isolation. He had withdrawn from friends and relatives for 2 years ever since the cancer was detected. He had a low self-esteem. He was totally dependent on his wife, even for his personal self-care activities, like wound dressing, giving him a bath, taking care of his diapers, everything was being done by his wife. So he had a very low self-esteem. He also had a sense of guilt because his family had given up all their activities. His wife had given up her job so that she could be his full-time caregiver. So he had a sense of guilt as well. And there was a role reversal because he was the head of the family, but now his wife had taken over all his responsibilities. So this is a summary of the various options to treat pain, which includes WHO 1, 2, and 3 step ladder. And then you have the various interventions that we use, like I told you, the basic and advanced, and of course the central neurodestructive. But remember, at every stage you need psychological counseling. So, and adjuvant therapy. So these are there at every step of the ladder. So if everything fails and nothing works, consider palliative solution. Accept failure, but never desert the patient. And be fellow travelers in their difficult journey. Be frank about failure, but convey it with sensitivity. Continue the psychosocial spiritual support and treat any worsening of the condition. Thank you.
Thank you so much, Mary ma'am, for that wonderful presentation. Now the forum is open for participants for queries. We do have already some queries posted in the chat box. You want me to read it out, ma'am, for you?
Yeah.
Just one moment.
1 minute. Let me just go to my full screen mode. Sorry, I'm not able to find my full screen mode.
Yes, ma'am. Just I'll be going through the queries one by one. Dr. Revati wants to know, does sublingual formulation of buprenorphine available?
Sublingual, I'm not very sure. I only know about the transdermal.
And I believe Dr. Neelima has responded to that query itself, that she thinks so used for opioid addiction.
It's one.
Ma'am, you're muted. Mary ma'am? Mary ma'am, you're muted.
Okay, unmute, yes.
Yeah, okay. And Dr. Rishikesh has raised his query. In opioid rotation, we stop the previous opioid and add the new one at the reduced dose. And then when do we titrate it to its complete dose?
That has to be done gradually. Whenever you want to increase opioids, you have to increase it after 3 to 5 days. Okay. And 3 to 5 days, you can go up step by step. Okay. But initially, you have to continue at that reduced dose.
So we stop the old opioid completely?
Which one?
So when switching over from the old to the new one, we stop the old opioid completely, start from the reduced dose, and then gradually increase the dose.
I think we have to continue that old opioid also for at least 1 day. I'm not very sure about that.
Okay.
And Shri Priya?
Yes, ma'am.
Cannot get the full screen. How do you go about it?
Okay. Just one moment, ma'am.
Can take over. Now I know. So I'll just now go on to gallery. No?
Yes, ma'am.
Okay. Right.
Okay. Dr. Muhammad Sajid wants to know, how does octreotide act?
Octreotide. Now, octreotide is a synthetic somatostatin analog. Okay. So it is basically your hypothalamus hormones. It is like that, but it's a synthetic analog. It decreases the it decreases the secretions. It has many effects. One of them.
Okay. Yes. So it reduces the pressure in the bowel.
Yes.
Okay. Thank you. Madam.
And it has got other side effects, I mean, other effects also, but the one for the bowel is the reducing the secretion.
Right. Thank you. Thank you.
Dr. Ashwin wants to know, how do we convert IV to oral morphine?
IV to oral morphine. So that is how you do. I think that has been dealt with in the previous class, right? How do you titrate morphine? Now, when a patient comes with severe pain, and then you do what is called a morphine titration. Okay, you start off with 1 mg morphine, and then you titrate it, and then you convert it to oral. I think that's been dealt with in the previous class, if I'm not mistaken. You go through the previous lecture.
Yes, yes. It was dealt with. It was dealt with in the previous class.
In titration.
Not the previous second class, second or third class.
Strong
After
opioids.
madam's class. After
Yes,
madam's class.
Yes, strong opioids class. It's the same as morphine titration, the same thing. And that's how you know how much morphine the patient will require when you're starting directly with morphine. Okay.
Dr. Ashwin, we would request you to kindly go through the contents provided for the management of pain 2 session and get back to us in case you have any further queries. Moving on, Dr. Sharon wants to know what factors could cause poor absorption of transdermal fentanyl or buprenorphine.
Transdermal fentanyl. I suppose factors like, when the patient is having high fever, okay, when the metabolic rate is high, then maybe it will not, either it will get absorbed too much, or, it'll be erratic. The absorption will be erratic when there's a vasodilatation or a vasoconstriction, because it has to go through the, get absorbed through the skin. So any factors, cold, clammy, or if there is a perspiration, all these things can affect. Or if there are some skin lesions, you should never put it on a skin lesion. But some of these factors can cause a very erratic absorption of the film.
Thank you, Mary. I believe Dr. Revati has further commented on her question. Dr. Revati, would you like to unmute and I believe it was regarding the sublingual formulation of buprenorphine.
Okay.
She says that it was available when it came to the market. It was suggested for MI pain, but later on taken away from the market. Anyone else would like to park any questions or any comments, insights before we move?
The main in difficult pain is, like I said, first of all, review the whole patient once again. Okay. And then after reviewing, you have to see whether the patient is taking many times you find that they're not following what you've told them to do. So the teach back techniques, you ask them to tell how they're taking the medicine, and then if there's any correction that needs to be done. So once you review, then you have to go through the pain, review the patient's pain characteristics. Has it changed? Is there a new type of pain that has emerged, or has a disease progressed? Once you do all that, and then maybe you will have to see whether give a combination of pharmacological and non-pharmacological. And in the non-pharmacological, there is a definite role of counseling, spiritual therapy, or other options like dry needling and all that. So you have to, it's a multimodal therapy that will work. It is not that one you give a medicine and that is going to work. You have to do a multi-pronged approach to treat these patients. That includes the pharmacological as well as non-pharmacological. Sometimes things like TENS and IFT, ice packs, etc. can also help. So, or positioning of the patient, if the patient is lying flat and the patient is having abdominal pain, you may need to just simple things like putting him on a Fowler bed and bending the hips and the knees, that itself can relieve pain. So these are the things that you have to think out of the box and see what ways you can help this gentleman. More than anything, it is a sympathetic doctor that is very important. When they know that you care for them, they will be amenable to your treatment. There is no magic bullet to treat intractable pain, okay? There's no single magic bullet. It has to be a multi-pronged therapy with an emphasis on total pain management.
Yes, Dr. Sharon, we see your hand raised.
Yes, ma'am, I have a query regarding the use of, like, suppose a patient who is having severe intractable pain, even on infusional, strong opioids. How often do you resort to things like, epidural or spinal blocks to just relieve that cycle of pain and, disrupt that cycle of pain? And if you do, that is the first question. And if you do use, spinal blocks or epidural blocks, how long do you give them before again trying to switch over to, other opioids or other analgesics?
See, the problem with epidural and spinal blocks, it can be used only for certain conditions, right? Thoracic related conditions or abdominal related conditions, or sometimes even for the legs. Okay. So, basically, you can see if you're using spinal, then there's a thing like intrathecal pumps, but they're very, very expensive. They cost 10 lakhs or plus, like that. I can't be afforded. But the other option that you can do, which is more affordable, is epidural blocks. And you can give epidural and put a disposable elastomeric pump. That's not very expensive. So that infusion can be given for a few days. They can go home with that. Of course, taking care that infection is a problem, but they have to be very, very particular about the dressing and things like that. And we have to review them. They have to come back. We can't just send them home and then, we have to make sure that we inspect the area, because we don't want any infection to set in. That is a problem of indwelling catheters. Okay. But epidural pumps with this pumps can be sent home with the patient. It can last for a week also. That's not a problem. Slow infusion of morphine or whatever can be given as an epidural infusion. And that can be used to supplement your oral analgesics as well. But the problem with all of this is malfunction. It can get blocked, it can get misplaced, and there's a problem of infection. So that has to be explained to the patient and taken care. The very personal hygiene should be very good for these people. Otherwise, it's better not to do that.
Yeah, thank you, ma'am.
Very ma'am, with your permission, can we move on to the case presentation for the day?
Yeah.
Dr. Neetu? You're muted.
Okay. Good evening, ma'am. Good evening, all. So I am Dr. Neetu. I am working as medical officer in Kerala Social Security Mission, Cherthala. Can I switch off the video? My network is not that
Sure,
much.
ma'am. Sure, no worries.
So, I am presenting the case of Ashokan, 65-year-old male patient. His presenting complaints was blood in urine and severe lower abdominal pain. His history of illness was patient who was apparently normal 5 years ago. Symptoms started as painless passage of blood in urine, and he underwent routine investigations like USG abdomen and pelvis, and it showed bladder technique and a small mass in bladder. Cystoscopy and transurethral resection of tumor was done, and HPE, and then the mass was sent for HPE, and HPE came as transitional cell carcinoma of bladder, and transurethral resection of tumor was done, and patient was symptomatically.
Dr. Neetu, you went on mute again. Sorry. Dr. Neetu?
Yeah. After 6 months, Again, the patient presented with a painless hematuria and underwent the same procedure, and he was better with that. Option of radical cystectomy was given, but the patient was not willing for that. And after few months, again, he presented with a vague lower abdominal pain and hematuria. Once again, the resection was done, transurethral resection was done, followed by chemotherapy. Then bleeding was subsided, but pain persisted. The patient was started on tab Altracet and amitriptyline, and the pain was decreased. After 7 months, the patient was presented with severe abdominal pain, and not the pain was not decreasing with Altracet and amitriptyline, and pain was associated with hematuria. Patient was started on morphine. 5 mg dose, 4th hourly. Uh, he underwent cystoscopy. At that time he underwent cystoscopy. The lesion was big enough and bleeding profusely and could not be controlled by cauterization. So underwent low dose radiotherapy with chemotherapy to control bleeding. After that also he pain subsided, but after a few days the patient again started complaining of pain in lower abdomen radiating to groin and lower back, which was colic in nature associated with vomiting. Pain aggravates at night and was unable to sleep. Pain did not subside with initial dose of morphine, and the dose of morphine was increased to 10 mg 4th hourly. Patient started complaining of breathing difficulty, and CT chest showed lung mets and features of aspiration pneumonia, and CT brain showed multiple brain mets. On examination, the patient temperature was normal, general condition was normal. The pulse rate, BP, SpO2 and systemic examination shows few cracks in chest, and other aspects are all normal. And psychological aspects, coming to psychological aspects, he was an ex-NRA businessman and was financially sound. He stayed with his wife who underwent chemotherapy for hairy cell leukemia 10 years back. His two sons were abroad with their families. His wife and eldest son was not emotionally supporting him, and wife used to abuse him when he was crying in excruciating pain. And uh, and the discussion points, coming to discussion points, how we can control pain at this stage, and how we can emotionally support the patient, and how can we motivate the patient for probable curative surgical option, and how we can treat aspiration pneumonia in palliative patients. Thank you. Thank you. Thank you.
I have one query. How much morphine was he getting?
Ma'am, 10 mg 4th hourly.
10 mg 4th hourly. So with that, what was his pain score?
Pain score was 7.
Even with 10 mg 4th hourly. And what are the other medications that can you show the medication chart, please?
No, I didn't kept that.
So what are the other medications he was getting?
He was getting amitriptyline because he had no pain, and because he had decreased sleep, he was given amitriptyline, and then morphine, then Dalcolax, bisacodyl for constipation, then for vomiting, metoclopramide. That's all, ma'am.
Okay. So anybody with any inputs on this case, please, or any doubts you have, you can clarify it before we discuss how to manage. Anybody? So his main problem is abdominal pain, right?
Pain, abdominal pain.
Is it continuous pain or is it a spasmodic pain? Does it come and go? Like, is it a continuous pain or is there incident pain as well?
It's not that continuous. It comes and goes.
It is more of a spasmodic pain.
Spasmodic. And pain was aggravating mainly during night. And patient can't able to sleep that because of that.
So the patient was getting 10 mg morphine 4th hourly,
Yeah, yes, ma'am.
mg at night, 10 p.m. dose was 20 milligram.
No, ma'am, 10 mg.
So that is one thing about morphine. When you're giving the night dose, you have to give double of the dose that you're giving in the daytime, because the next dose you want to give it only at 6 in the morning.
Ma'am,
Yes.
did you ask any question?
No, what I'm telling is that 10 p.m. dose should be double what you're giving in the daytime.
Daytime 10 mg, ma'am.
So night dose has to be 20 milligrams.
Okay, we have to double that.
Yes, because
Okay.
from 10 p.m. to 6 a.m., we don't want to disturb the patient at night. So you have to give double the dose of whatever drug you're giving. If it is 5 mg morphine, you must give 10 mg. If it's 10 mg, you must give 20 mg. So whatever the dose you're giving the daytime, the night dose has to be double that. Along with that, are you also giving paracetamol?
No, no, ma'am. Paracetamol not give.
So if you follow the WHO analgesic ladder, then you have to give a non-opioid as well along with this.
Okay.
And there could be a neuropathic component. We cannot rule out a neuropathic component because there could be nerves involved in it. So you may have to add an anticonvulsant also in addition to the antidepressant. How much amitriptyline are you giving?
25 mg HS.
So that's a good dose, but you can add a gabapentin as well to this treatment.
Okay.
And you can add paracetamol 6 hourly in addition, and double the dose of morphine at night.
Okay.
Are you giving any sedative at night?
No, only the amitriptyline is giving. No,
You can add a sedative as well, like lorazepam. There must be a lot of anxiety, and he's going through a lot of emotional pain also. So you can add a drug like clonazepam, okay, clonazepam or lorazepam. Clonazepam will be preferable because it is considered one of the only drugs in benzodiazepine that is effective for neuropathic pain. So you can give clonazepam 500 micrograms or 0.5 mg at night. So these are the things that you can add to make sure that you're taking it, attacking it at all angles. Okay, you're not going in a single path, but we're trying to have a multi-pronged approach. Right. But paracetamol definitely you should add to this treatment regime. Or don't combine tramadol with morphine, but paracetamol non-opioid can be added.
Okay.
That is some way of titrating the medical therapy of this person. And what is his pain score at the moment?
At the moment was 7, ma'am. It's
and the pain is more at night.
Yeah, pain
more at night. So you have to night dose. You have to give a little more. Like I told you, morphine can be increased at night, and you can even give double the dose of paracetamol at night. You can give up to 1 gram at night. Only thing, make sure that the total dose of paracetamol doesn't exceed 4 grams.
Okay.
Okay. So that way you can take care of his night pains. And this gentleman has got metastasis. Okay. Lung metastasis and brain metastasis. So what is the role of radical cystectomy? There is no role. He's already gone into the metastatic stage. So by doing a cystectomy, you're not going to achieve anything because his lifespan is now limited, right?
Yeah.
That is a major procedure. So that may not be the right option in this gentleman.
Okay.
And aspiration pneumonia. Why is he getting aspiration pneumonia?
Ma'am, he is
Because aspiration pneumonia occurs only when the patient is semi-conscious and it is going into the lungs, right? Now, in this gentleman, why is he getting aspiration pneumonia?
Maybe because he is not, laying down because of pain. He is not waking, sitting and taking food. Maybe because of that.
See, only when the cough reflex is poor will a patient aspirate. Okay. So if he is fully unconscious, even if he is lying down, I don't think that is a reason for aspiration pneumonia to happen. It could be hypostatic pneumonia because lying down all the time can cause basal congestion and that can cause hypostatic pneumonia. It's mainly in the bases. If the X-ray is done, can you tell me where exactly the pneumonia is?
What, ma'am?
The X-ray chest, where is the pneumonia? Any idea?
No, the lower lobe, ma'am.
That is because of basal congestion. Because of lying down in the position without any movement, it can cause what is called hypostatic. It's unlikely to be aspiration.
Okay, ma'am.
Emotional support of the patient. So that is very important because he's having so much pain that he's irritating his wife. You see, his wife is also abusing him emotionally. Okay. So we need to counsel the wife.
Yes,
That counseling needs to be done for the caregiver. See, the caregivers are under immense strain when treating patients with cancer. And they can be, they can get sometimes very irritable, angry also, because they are also going through a lot of trauma. So we need to counsel this lady, and maybe she's under a lot of stress. Maybe she needs a stress buster and stress relieving techniques also. So there are some places where the caregivers are also given stress relieving modalities. I've heard of the caregivers of children with cancer. They have taught dance, aerobics, just to relieve their stress. Okay. Can you imagine the parents of a child with cancer, what they are going through? So they are also under a lot of stress. The same thing happens to even the spouse of the patient. They are also under a lot of stress. So if you don't counsel them that, this is something that it's not the patient's fault, it may be for a limited time, but you have to understand. There are various ways of counseling these people that may need to be done for the wife so that her attitude to her husband improves. You can't blame her, but maybe you can counsel her.
Okay, ma'am.
Okay.
Okay.
Like I told you about that patient I discussed. You see how many factors he had. You see how many psychosocial factors he had that could probably accounted for the perpetuation of his pain.
Yes, ma'am.
Because emotional pain is also a very, very huge thing. Even if you treat the physical pain, if there's emotional pain, they will still feel pain. It may not be physical, but it's an emotional realm. So that is also equally painful as a physical pain. So that needs to be addressed.
Okay, ma'am. Thank you.
Any other inputs or anybody wants to comment on this or any other input for the treatment for this patient?
We have a few comments in the chat box. Dr. Jaya had said patient controlled analgesia, hypogastric plexus block. Dr. Jaya, would you like to unmute and give more insight on those? Or anyone for that matter? Because I see a number of comments, but all are in brief. Okay. Dr. Revati Sharavanan had suggested sedation at night, just what Mary ma'am had said earlier.
Hypogastric plexus block can be considered in this patient because they are blocking the sacral pelvis, sacral plexus, and which is the one that is causing the pain in bladder and all the pelvic organs. So that is one of the options that can be. Or even epidural is also good. But in this patient, we don't need to do opioid rotation, because you can keep stepping up the dose of opioids till toxicity appears. So one indication for opioid rotation is when there is neurotoxicity symptoms, like hallucinations or oversedation or hyperalgesia. That's when you have to go for opioid rotation. Otherwise, you can just increase the dose of morphine. From 10 mg, you can make it 20 mg 4-hourly, with a doubling of the night dose. Okay. So opioid rotation may not be the thing. You can go higher up on your opioid requirement.
Thank you, Dr. Jaya, for that message that you are in examination center, but that message means that you are paying full concentration to the session. That is much appreciated. Dr. Vandana, you see your hands raised? You're muted.
Yes, ma'am.
You're muted.
Once. Yes. Good afternoon, ma'am. Can you hear me now?
Yes,
Yes,
yes.
yes. Perfect.
Ma'am, thank you for the excellent talk, ma'am. I have two doubts. They are not related to this case presentation, ma'am. And my apologies if I have missed the slide in between, because there was some connection problem. One is, can magnesium be used in the, what is the role of magnesium in difficult pain? Because we have a lot of studies coming up regarding the use of magnesium for pain nowadays. Especially, I'm an anesthesiologist, so it does help. That's what studies say. So any role. That is one of the doubts. And in difficult pain, again, is there any role for alpha-2 agonists like dexmed and clonidine? These are the two, especially clonidine, because it can also be given orally. So dexmed oral is not available, but about clonidine, is there any help?
See, clonidine can be combined with drugs to give either orally, or you can even give it epidurally as well, right?
Yes, ma'am.
So it is one of the things you can give it to prolong the action of the drug. Clonidine is an option, but dexmed, I'm not very sure whether it can be used. It is alpha-2 agonist, no? Dexmedetomidine.
Yes, yes, yes.
Yeah. So it is good for sedation, right?
Yes, ma'am. So in these kind of patients who are having pain in the night, maybe a dexmed infusion could be of some help.
See, the problem with dexmed infusion is it has to be given in the hospital. It has to be given with,
Yes, ma'am.
and these are the
Monitoring, yes.
patients who are at home. So it
Home,
may not
okay.
be the best option, dexmed, because
Okay.
very few of
Okay.
these patients are in hospital. Most of them are at home. If they're in
Yes,
hospital, probably added, but not for home domiciliary use. It may not be effective. Okay, so
yes,
I don't think
yes.
it is a very good option for the management of cancer pain, particularly this refractory pain, because these are the patients with terminal cancer. And if they are being nursed at home, then I don't think you can give dexmedetomidine.
Okay. Okay. Ma'am,
Clonidine-
does magnesium have any role?
I have no idea. Maybe I'll look up and see about it.
Okay. Thank you, ma'am.
Dr. Revati had further commented that it will not be effective when there is severe pain without analgesics. So, Dr. Kanmani wants to know, in burst ketamine, if patient responds to 100 mg per 24 hours dose, how long do we need to continue the infusion? How do we taper it?
This is basically a 3 to 5 day regime. That's all. Okay. So you have to stop it after that. It is basically to stop the whole cycle of pain. Like, for example, xylocaine infusion. You give it only for 1 hour. Okay. and then you stop it at the end of 1 hour, and then you can repeat it after 2 days, but then don't give it more than 2-3 times. There's no role of that. So basically all these things are, this is a 5-day therapy course. That's it. Okay. And don't continue it beyond that. But in that, it may break the cycle of pain by blocking the NLD receptor. It's not a continuous that you have to continue giving it.
Anyone else would like to share their inputs or thoughts or any further queries?
In this particular patient, there could be a role for antispasmodics also, because the pain is coming intermittently. So maybe there is a role of hyoscine butyl bromide or one of those like methyl spaz and things like that, which can dicyclomine, which can reduce the spasms, because it's a spasmodic pain. You can think of the role of antispasmodics as well. You can add it to the as an adjuvant. You can add it like an adjuvant.
How long can we give the cyclopam, ma'am? How long?
Can be given. Or you can give it on an SOS basis also.
Okay.
Dr. Kanmani also suggests that DEXA can be added for brain mets.
Yes. But right now, it's not the brain meds that's troubling him. It's abdominal pain that is troubling him. But dexamethasone can have a role even to treat abdominal pain by reducing the inflammation because of its potent anti-inflammatory effect and its feeling of well-being. So in many ways, a short course of dexamethasone can also be added if the pain is unbearable. Give it for 5 days and then stop, 5 to 7. Any other inputs? We have got another 10 minutes left. Anybody wants to comment?
I believe no. In that case, maybe we can wind up for the day a little bit earlier so that everyone can have their evening tea in peace. Thank you, Dr. Mary, for joining us. It was very nice to go through your session once again, and we do look forward for more sessions in future as well. Thank you for your time. Thank you, participants, for joining in. And before signing off, just a gentle reminder that we have already issued 2 assignments. The second assignment has been released now in between the session to the group, and kindly do complete that. So with that note, this is Sri Priya along with Dr. Mary Abraham signing off from the Tips Eco Hub. See you in the next session with another interesting topic and another eminent faculty. Till then, everyone, stay safe, be happy. Take care. Bye-bye.